Hello friends, I am Dr. Rishi Sethi, Consultant Ophthalmology, Northern Railway Central Hospital. I am going to demonstrate a case which was planned for Phaco, but due to Rex's run out, I had to convert it to an mSICS on table. So here I am doing the usual process which is common in both mSICS and Phaco, where I have made side ports and injected dye. Now I am injecting viscoelastic. So as I have completed the procedure, I begin my usual capsulorhexis. I lift the flap with a cystitome. As I am trying to lift it, the rhexis becomes uncontrolled and starts going to the periphery. So here it is my attempt to rescue it, but as I try to rescue it, further runs away and goes beyond it. Seeing there is no point of rescue, I try to convert it into a can opener capsulotomy, where I am giving multiple small nicks in the periphery, which is the crucial for can opener technique. Here I am making sure that the nicks are very small and they are in a very continuous large fashion. Also I am making sure that it is completed from the inferior portion also. Here the inferior can opener capsulotomy is being completed. In this way, I have given around 40 to 50 small cuts, nicks, which is helping me to convert the continuous curvilinear capsulorhexis into can opener capsulotomy. So it is a pretty decent large sized capsulotomy. I am making sure that each and every tag is detached from the capsule. The anterior capsule, which I have separated from its periphery, should not leave a large tag which might come in my surgical process. Now I am taking a Birdle suture, taking superior rectus, passing a suture through it to stabilize the eye. Now I am doing a conjunctival peritomy. After this peritomy, I will give an incision with a 15 numbered blade, a frown incision. Now I will make a partial scleral tunnel with a crescent blade. The importance of this tunnel is that it should be large and it should be complete in the side pockets so that the nucleus is engaged well. After confirming that my pockets are large, I am making an entry through a 2.8 keratome. Here it is important that you do not give undue pressure to the eye so that the visco does not come out. Now I am using a dialer to prolapse the nucleus into the anterior chamber. With the help of viscoelastic expression, I am able to deliver the nucleus out of the tunnel. Here you can see a lot of cortical matter is left, which I am trying to remove through visco expression. Since small cortical matter is left in the inferior portion of the eye, I will irrigate and try to aspirate the cortical matter slowly. Since my capsulorhexis is not complete, it is a can opener capsulotomy, there are chances that I may catch hold of the tags. So I am making sure, and I am doing very gentle aspiration to remove the cortical matter. So after the center chamber is cleared of the cortex, you can proceed with the insertion of IOL and then do cortical wash at a later stage. Now I have put some viscoelastic and I am proceeding with the insertion of intraocular lens. I am putting a foldable hydrophobic intraocular lens which was planned for a phaco surgery. Now I will try to dilate and try to dislodge the cortex from the place it is stuck. So this gives me a kind of support and it can save me from rupturing the posterior capsule. Now you can see the inferior cortical matter has been displaced from its original position and I am able to remove it through a Simcoe cannula. Now I am doing the visco wash. Here small bit of cortical matter is still stuck, which can be easily removed using the posterior chamber intraocular lens as a scaffold to prevent posterior capsule rupture. The beginners may use the side port, but if the tunnel is nicely made, then you can use the main port. So I am hydrating the two side ports which I made and checking the intraocular pressure of the eye. And now I will give Genta-Deca injection and close the case. Thank you friends for listening.